This conference will now be recorded.
So today we are going to discuss the talk from the April 2020, that is WHO type 1 anovulation. This talk discuss, sorry. Hmm, okay. So this talk mainly discusses about the WHO type 1, that means hypogonadism type of anovulation and its management type. So there are three types of this hypogonadism. So it is going to discuss about the causes and what is the management difference in these three different types of type 1 anovulation. So according to WHO, the anovulatory ovulation disorders, they are classified into three types. Type 1, where there is gonadotrophin levels are low, estrogen levels are also low. So this is mainly because of either hypothalamic or pituitary dysfunction, that is central dysfunction, HPO axis central dysfunction. Type 2, it is where the gonadotropins are almost normal, estrogen levels are normal. This type 2 is the most common type of anovulatory disorders, and it consists of all the important things like PCOD. The most common type of type 2 is the PCOS, and type 3, it is high level of gonadotropins and low estrogen. Okay, so it is basically ovarian failure. So these are the three different types of WHO anovulation disorders. Now in this talk, we are considering only type 1. Okay, so before going to the anovulation, to just revise the physiology of ovulation. Okay, so basically GNRH, which is released in pulses from the hypothalamus. The frequency of this GNRH pulses varies throughout the menstrual cycle. In follicular phase, the pulses occurs at the interval of 90 minutes. Luteal phase, the pulses occur at the interval of every 3 hours. With onset of puberty, nocturnal gonadotropin. Nocturnal gonadotropin secretion increases, mostly LH, reflecting increase in the GnRH pulse amplitude. This FSH and LH, they both rely on this GnRH pulse secretion. Okay, so LH pulse, it is followed by FSH pulse within 30 minutes. The gonadal steroids, that is estrogen progesterone, that begins to rise with the pubertal onset. As the puberty progresses, so as I told you, before puberty, there is mostly nocturnal gonadotropin secretion. After puberty, there is wake time gonadotropin pulses, they increase in frequency, and sleep associated pulses, they decreases. In more advanced puberty, there will be loss of this diurnal variation, and the positive feedback mechanism of this gonadotropin ensures, which give rise to estradiol triggered LH surge and ovulation, and then regular menstruation will be established. So hormone levels in routine menstrual cycle. So you can see this dotted line is of FSH. So in the mid follicular phase, the FHS rises. It will responsible for the recruitment of follicles. And again, at the time of again it rises. Then throughout the luteal phase, the levels are decreased. And at the time of menstruation, again this FSH levels rises. LH level, these are at baseline till the LH surge, that is just before the ovulation. Okay, and this is because of positive feedback mechanism, this LH surge occurs. Estrogen, progesterone, they both rises in the basically luteal phase, but estrogen has this double peak. So at the time of ovulation and again in the luteal phase. And progesterone is mainly responsible for this luteal phase maintenance. So as we all know, there is two cell, two gonadotropin theory. So this theca cells with this LH, theca cells produce this androgens. These androgens, they are not converted into estrogen in this theca cell because this theca cell, these lack the enzyme P42, cytochrome P450 aromatase enzyme. which is deficient in this theca cells and which is present in granulosa cells. And this enzyme is important for the conversion of this androgens to the estrogens. And this is present in the granulosa cell. So on the with this FSH receptors, this act on the granulosa cell, they convert these androgens into the estrogen in the granulosa cells. And the main estrogen is, which is present in the body, is 17 beta estradiol. Now, how this hypothalamus is regulated, that is HPO axis. So hypothalamus is basically this GNRH secretion is done by these GNRH neurons, and here the positive and negative feedbacks are there. So positive feedback is by this kisspeptin neuron, and this kisspeptin neurons, kisspeptin is the hormone which is required for puberty onset and maintenance of normal reproductive function. So this is a new thing that they are trying for this subfertility, that is WHO type 1 ovulation, anovulation. And these candy neurons, this causes this negative inhibitory influences on this GNRH neuron. So GNRH neurons, in the presence of this kisspeptin, they secrete this GNRH, which in turn acts on the pituitary, which is responsible for the gonadotrophin secretion. And this FSH and LH is responsible for the production of estrogen and progesterone by the ovaries, which will again exert this positive and negative feedback mechanism on the hypothalamus. So this is basically the physiology of this menstruation. Now coming to the type 1 anovulation, there are these 3 types. One is hypogonadotrophic hypogonadism. Okay, so usually there are 3 types, I will tell you. One is hypogonadotrophic hypogonadism, second is hypothalamic amenorrhea, and third is this pituitary dysfunction, okay, that is hypopituitarism. So these are the 3 basic pathologies behind this WHO type 1 anovulation. So we will consider each and every cause in detail. So coming to the hypogonadotrophic hypogonadism, which is also known as HH. Okay, so the causes of this hypogonadotrophic hypogonadism, they can be either congenital like Kallmann syndrome or KIS1 mutation, that is kisspeptin mutations. Infiltrated disorders like hemochromatosis, sarcoidosis, vaginal granulomatosis, and histiocytosis. Then drugs like glucocorticoids and narcotics, which give a negative feedback mechanism on this GNRH neurons. Infections like meningitis, encephalitis, and tuberculosis. So any CNS infection, again it will release this inhibitory impulses. Head trauma and space occupying lesion of the brains like craniopharyngioma, glioma, germ cell tumors, hematomas, teratomas, and any treatment like surgery, chemotherapy, or radiotherapy. So these are all responsible for this hypogonadotrophic hypogonadism. So here the FSH-LH levels will be low because of deficient GNRH secretion. Now this is because of deficient GNRH secretion. Hypopituitarism is different. Hypopituitarism because of primary pituitary dysfunction. Okay, while this hypogonadotrophic hypogonadism is because of deficient GNRH secretion. So how you are going to assess this HH? So it usually there will be amenorrhea. It can be primary or secondary depending upon the cause, whether it is a congenital or acquired causes. It depends upon that whether it will be primary or secondary amenorrhea. Gonadotrophin's concentration will be very less, like FSH, LH, and estradiol. So all will be decreased. Then when the causes are acquired, like tumors, they have other symptoms like neurological symptoms, growth problems, and other hormonal dysfunctions like diabetes insipidus. By contrast with hypothalamic amenorrhea, these hypo patients, they can be overweight or obese. Okay, so hypothalamic amenorrhea we will come to later on. So we again that time you will understand. But this hypo, these patients are overweight or obese. Now on ultrasound, sorry, the ovaries might be small, very small, because of very low levels of FSH and LH or gonadotrophins, or sometimes there will be very that is large number of antral follicles will be seen, that is which is called as multicystic ovaries. Okay, so as you know, after this antral follicles, these are antral follicle pool will be already present in the ovary, and if this gonadotropin act on this, then only it is going to develop into the mature follicles. So this pool might be present, and this pool will give rise to this multicystic ovaries. AMH is less useful for ovarian reserve test in this hypo-hypoc patient. So how you are going to do the ovarian reserve assessment? By seeing the response of ovary by the gonadotropin stimulation. So when you give the gonadotropin hormones, how much the ovary responds, it depends. So from that, you are going to measure the ovarian reserve in these hypo-hypoc patients. Now coming to the hypothalamic amenorrhea. So this is a distinct entity. This is basically because of this, either because of psychological like stress, eating disorders, excessive exercise, nutritional deficits, critical illness, and chronic illnesses like malabsorption syndromes like celiac disease or inflammatory bowel disease. So what happens in hypothalamic amenorrhea? It is a neuroendocrine disorder usually caused by energy deficit and low leptin levels. This hypothalamic amenorrhea is a diagnosis of exclusion, and it will be present as amenorrhea with hypoestrogenic state, which is reversible. So hypothalamic amenorrhea is a reversible cause. Remember well, this condition, it can either present as primary amenorrhea with delayed puberty and delayed menarche, but usually it is present with secondary amenorrhea. And this hypothalamic amenorrhea is responsible for 30% cases of secondary amenorrhea. So this hypothalamic amenorrhea, when it occurs in weight loss or nutritional disorders or eating disorders. So when the BMI falls below 19, or when the body fat loss occurs below 20%. So when the total body fat falls below 20% or BMI below 19, this hypothalamic amenorrhea results, and it is seen more frequently if the weight loss is done very rapidly. Again, as I told you, stress is a reason of this hypothalamic amenorrhea. So what happens with stress is it activates the hypothalamo-pituitary adrenal axis. So because of stress, increased levels of steroids and CRH, that is corticotropin hormone secretion. So that will result in the increased cortisol from adrenal gland, and it will cause an inhibitory influence on this GNRH. So there will be decreased release of GNRH or reduced GNRH drive. So it is this is the way where this stress is responsible for hypothalamic amenorrhea. So stress will cause increased steroids, and this increased steroids will inhibit the GNRH secretion. Then, as I told you, weight loss, chronic diseases, so all diseases associated with the lower leptin levels. Okay, so this anovulatory and amenorrheic woman here, they display lower leptin levels than women with normal menstruation. So kisspeptin, as I told you, kisspeptin is responsible for positive feedback mechanism. So it has got positive influence on the GnRH secretion. So this kisspeptin increases LH pulses in women with hypothalamic amenorrhea, and kisspeptin can induce oocyte maturation in dose-dependent manner. So they have tried this kisspeptin, but still it is not yet recommended for this hypothalamic amenorrhea. Okay, but it can be a novel drug. So it can be a novel treatment strategy in the future. So how you are going to assess this HA or hypothalamic amenorrhea? So mostly it will be secondary amenorrhea with low gonadotropins and low estrogen. So see, in HH also, hypogonadotrophic hypogonadism, there will be definitely low FSH, LH and low estrogen. While hypothalamic amenorrhea, the FSH and LH will be lower, or it can be normal also, and they will be not very low levels. Okay, so it can be up to lower normal or normal levels of gonadotropin, but estrogen will be less. Secretion of LH is significantly affected than LH, and normal level of gonadotropins, it do not exclude the diagnosis of hypothalamic amenorrhea. So in HA, the gonadotropins either can be low or either can be normal, but these two are not distinct entities, but these are the different points in the presentation of this disease. So these are not two different entities, but first there will be normal, and then it will be decreased if this weight loss continues. Also, because of this hypogonadism, there will be diminished, because of lower estrogen levels, there will be diminished bone mineral density with increased risk of osteopenia and osteoporosis. So whenever you are assessing this primary or secondary amenorrhea, you have to always take a detailed personal history, like history of any stressors, eating disorders, or heavy exercises. And on ultrasound, what do you think, what do you find out is usually polycystic or multicystic ovaries are found in 30 to 50% of patients. So you can see here in this A figure, you can see again polycystic ovary, but here you can see the stroma is more. So thickened stroma is there. While in case of multicystic ovaries, there will be very less stroma. So this is a hypothalamic amenorrhea or hypogonadism ovaries. Here there will be cyst will be there, but the stroma will be relatively very less. So this is how you can differentiate between this two ovaries, PCOS and multicystic ovaries. Also, another clue for this hypoestrogenic state. So how, again, if you find this PCOS or multicystic ovary featured, how you are going to differentiate between the PCO and hypothalamic amenorrhea is by the endometrial assessment also. So there will be thin endometrium because of hypoestrogenism. And this endometrium will not respond to progesterone challenge. So with the women of secondary amenorrhea with progesterone, they are not going to regain the menses. So this is the thing where you have to, because PCO, you know, if you give this progesterone challenge, they are going to have this withdrawal bleed. But hypothalamic amenorrhea patient, they are not going to respond to the progesterone challenge because of estrogen is very deficient in these patients. Again, AMH levels, they vary, they also varied in this hypothalamic amenorrhea, and again, they are not very reliable for this response, okay? So again, you cannot rely on the AMH level for the ovarian reserve. Then, what are the investigations what are required for this hypothalamic amenorrhea? So if the patient who is presenting either with primary or secondary amenorrhea and whom you are thinking she is having hypothalamic amenorrhea, you have to do brain MRI only in case if the patient is giving history of any severe or persistent headache, persistent vomiting, any neurological symptoms, change in vision, thirst, or urination. Okay, so whenever you are getting any clue regarding any pituitary hormone deficiency or excess or any neurological symptom, then only you are going to do brain MRI. Routinely, brain MRI is not required for hypothalamic amenorrhea patients. But any adolescent or secondary amenorrhea, whenever the amenorrhea is more than 6 months or more, you have to do the BMD measurements for those patients to rule out any osteoporosis. So this is an important table in this talk. Here they have differentiated between this hypogonadotrophic hypogonadism, hypothalamic amenorrhea, hypopituitarism. So these are the three types of this type 1 anovulation, while this is type 2, that is polycystic ovarian syndrome. So as you can see, gonadotrophins in hypothalamic, in type 1 anovulation, they will be low. Only thing in hypothalamic amenorrhea, they will be either normal or low normal. They will not be very low. While in PCOD, they can be either normal or LH can be high. So FSH LH, they will be decreased in hypopituitarism, while for hypothalamic amenorrhea, they may be either normal or low normal level. Estrogen is everywhere in type 1. In all three types, estrogen will be low, while in PCOS, it will be normal. AMH, in hypo-hypoc, it can be normal or low. In hypothalamic amenorrhea, you cannot predict. It can be either low, normal, or high. In hypopituitarism, it can be low or normal, while in PCO, you know it is high. Ovarian morphology on ultrasound. So in hypopituitarism, because there will be very low FSH and LH, the ovaries will be small. While for hypo-hypoc and hypothalamic amenorrhea, there can be either multicystic appearance, or if the secretion of FSH and LH becomes very low, the ovary can become very small. While polycystic, you know, they are high volume and the polycystic appearance of ovaries. Uterus in all three types will be small, while for PCOS it is normal. Endometrium in all three types, again it is thin because of less estrogen, while in PCOS it is thick. Body weight in hypothalamic amenorrhea it will be low, while in other condition it can be either normal or it can be high also. And period pattern, as I told you, hypothalamic amenorrhea, it usually presents with secondary amenorrhea. Hypo-hypoc depends upon the cause, but it can be either primary or secondary. Hypopituitarism, again primary or secondary. And usually PCOS, it is secondary amenorrhea or oligoamenorrhea. So this is the table which differentiates between this all anovulation values. Now coming to the hypopituitarism. Hypopituitarism, it is basically due to the primary pituitary dysfunction. Okay, so it can be because of empty sella syndrome, aplasia or hypoplasia of anterior pituitary, isolated pituitary hormone deficiency, that is single hormone deficiency or multiple deficiencies, syndromes associated with pituitary hormone abnormalities, any trauma, any infection or inflammations, any infiltrations like hemochromatosis, Langerhans histiocytosis, chronic transfusion or thalassemia, pituitary tumors or treatment with surgery, radiotherapy or chemotherapy, and Sheehan syndrome, that is postpartum pituitary necrosis. So all these are causes of hypopituitarism, which is responsible for type 1 anovulation. How you are going to assess this is decreased secretion of pituitary hormones. So there will be, along with FSH and LH, there can be other hormones will be also affected. Usually the woman can be asymptomatic, or they will present with symptoms related to other hormone deficiencies also, or neurological problems because of any mass lesion. So secretion of growth hormones and gonadotropins, these are the more commonly hormones which are affected by organic pituitary disease. The diagnosis is usually made on the basis of reduced level of ACTH, cortisol, FS, LH, estradiol, TSH. So as I told you, all hormones, most of the time, multiple hormones will be affected, not all, but multiple hormones from the pituitary will be affected. Ultrasound, usually they will be smaller ovaries, okay? And uterine measurements also they will be lower, okay? So the uterus will be very small than in women with HH or HP. And isolated growth hormone deficiency also, there will be uterus is significantly small. AMH levels, it can be either low or high. So what is the treatment for this type 1 anovulation? So first is hormone replacement therapy. Like if you say the patient is having primary amenorrhea, you have to give her hormone replacement therapy to induce puberty and the maintenance of menstruation also, and along with that to prevent osteoporosis and other cardiovascular problems. So any hypothalamic amenorrhea or hypopituitarism before puberty, the treatment should be started with estrogen to induce puberty. And because delayed puberty, it has a psychosocial well-being and other problems also. And progesterone should be added to estrogen as a HRT once the bleeding is achieved. Okay, once the breakthrough bleeding with estrogen occurs, then you will be adding progesterone to it. In young women, the strategy what they previously used is using combined pills. Okay, combined pills, they are used in place of natural estrogen for hormone replacement therapy. But Endocrinological Society, they have not recommended this thing. I will come to this later. But COCs are usually not given for maintenance of menstruation in these patients. If the fertility is not a consideration, further management for this HRT, it depends, it usually consists of estrogen plus progesterone HRT to ensure adequate development of secondary sexual characteristics, treat symptoms of any estrogen deficiency, maintain bone mineral density and cardiovascular health. And how HRT will be continued up to the natural age of menopause in these patients. So, as I told you, Endocrine Society, they advise this hypothalamic amenorrhea woman against using oral contraceptive pills because this can mask the return of spontaneous menstruation and the bone loss can continue if the woman maintains this energy deficit. So what happens with hypothalamic amenorrhea? Basically, this is because of low energy levels. Okay, and if you treat it with conservative management, like increase the weight gain and with a dietary and control on the exercise, they may return their natural menstruation again. And if you start her on OC pills, it will inhibit the return of spontaneous menstrual cycle and bone loss will continue. So in these patients, transdermal natural estrogen with cyclical progesterone is recommended in teenage girls and women who had not returned the menstruation after a reasonable trial of nutritional, psychological, and modified exercise intervention. So, first line of treatment for hypothalamic amenorrhea is the nutritional intervention, psychological, that is CBT, and modified exercise routine. Okay, and if with that, if the menstruation is not returned, then instead of COCs, you will be adding transdermal estrogen with cyclical progesterone. Biphosphonate, denosumab, testosterone, leptin, all these improve bone mineral density, but this should not be used in women with hypothalamic amenorrhea. Remember well. So in hypothalamic amenorrhea, you are not going to use combined OC pills. You are not going to use any biphosphonates, any testosterone or leptin. Now for prevention of cardiovascular disease in this patient of hypoestrogenism, because all these type 1 anovulation patients, they have decreased estrogen levels. So it increases serum cholesterol levels, VLDL levels, LDL levels, and triglyceride. Also reduction in SHBG levels. So it adversely impacts the cardiovascular health. And what they have found out in studies is the angiographic evidence of coronary artery disease is more likely when the serum estradiol is less than 50 and FSH and LH is low level, while comparing with the normal estrogen and normal FSH. So the timely estrogen replacement reduces the risk of ischemic heart disease and improves the cardiovascular health in these patients. So for that reason, this HRT is recommended for this patient and it should be continued up to the natural menopause age. Lifestyle changes and non-pharmacological measures. As I told you, for hypothalamic amenorrhea, all these patients, they should have this increased caloric intake, reduced intensity of exercise. So it will cause the increase in the weight gain and resumption of menstruation. So the calorie intake, minimal goal is 30 kilocalorie per kg. It helps to reverse the hypothalamic suppression. And when the weight gain occurs and it achieves, the BMI achieves up to the 90% of standard body weight, if it is achieved, then usually they resume this menstruation within 6 months of this ideal weight goal. Okay, so when this weight gain is come up to the level of 90% of standard weight, then they usually resume the menstruation within 6 months of this achieving of normal weight. CBT will also be useful in these patients because they will have, most probably they will have the stress and eating disorders. Leptin therapy, it is under study, but still the number of participants are very less. Periods evaluated is very short and follow-up is not up to the mark. So that's why still leptin is not recommended for this hypothalamic amenorrhea patients. Now, what are the fertility treatments? Most of the times you get EMQs on this. So first of all, for hypothalamic amenorrhea, you will be improving the general health. That is optimization of body weight and treatment of any chronic disease. Now, for ovulation induction, there are two options, either pulsatile GNRH stimulation or gonadotrophins. Okay, so when you will use this pulsatile GNRH and when you will use this gonadotrophins for this ovulation induction. So this is the talk which gives you answer, because previously it was not clear where you are going to give this pulsatile GNRH and when you will give this only gonadotrophins. So these are the two options. I will come to that later, exactly when you will be giving these two differently. But if the ovulation induction is not achieved with either pulsatile GnRH or gonadotrophins, then the next option remains is IVF. The women with hypothalamic amenorrhea who have high serum AMH levels and multifollicular ovaries, and they have some normal up to low normal of estrogen, they can be also given clomiphene citrate for ovulation induction. And these multicystic ovaries, if they are for IVF, they are at high risk of OHHS. So first ovulation induction is only used when the BMI is achieved at least up to 18.5. Okay. So first you will be providing the conservative management to optimize the body weight, increase the diet, reduce the exercise levels. Why? Because this is associated with increased risk of fetal loss, SGA babies preterm, and cesarean section deliveries in case of underweight woman. So for this, basically ovulation induction is started when the BMI is more than 18. So BMI should be at least 18.5. Okay. Kisspeptin and leptin, these are not used for subfertility. So for fertility treatment, kisspeptin and leptin are not used for this hypothalamic amenorrhea. Now, hypothalamic amenorrhea, this is the condition where you will be using this pulsatile GNRH treatment. Okay. So pulsatile GNRH is used for hypothalamic amenorrhea, and sometimes for this hypo where the cause is solely because of this GNRH problem. Okay. So here these are the conditions where you will be using pulsatile GNRH. Clomiphene can be used, as I previously told you, if the FSH, LH, these are up to the normal. So gonadotrophin levels are normal or low normal, or if the ovaries are appearing multicystic, here you can give a trial of clomiphene before starting pulsatile GNRH. So usually the length of ovulation induction, cycle length will be 10 to 20 days. And minor adverse effects with this GNRH pulsatile treatment, it includes nausea, breast tenderness, and bruising at the injection site. The monthly conception rate is about 20%. It may take few months to achieve pregnancy, and risk of multiple pregnancy with this pulsatile GNRH is 5 to 10%. Okay. So, and these people will also require estrogen treatment before starting ovulation to get a proper endometrial response. Okay. So, before starting GNRH, pulsatile GNRH treatment, better to start them on first estrogen for at least 2 to 3 cycles to achieve a favorable endometrium. So, as I told you previously also, so low normal gonadotrophins with estrogen levels who have the endogenous estrogen levels preserved, you can use them clomiphene for ovulation induction. Okay. So if the gonadotrophin levels are normal, endogenous estrogen is present, you can first give trial of clomiphene citrate before starting on GNRH pulsatile treatment. So this pulsatile GNRH is only used when this pituitary is intact. So whenever there is hypopituitarism, there is the place where you will be using this gonadotrophins. Okay. So for idiopathic hypogonadotrophic hypogonadism and hypothalamic amenorrhea, these are the places where you will be using pulsatile GNRH treatment. Here the GNRH can be either used by pump infusion at the pulse interval between 60 to 180 minutes. Okay. And best outcome is observed with pulse frequency of 90 minutes. Also, GNRH can be administered by IV, subcutaneous, intramuscular, nasal, or sublingual route. The subcutaneous route is commonly used. Dose of 15 microgram is used. Okay. And pulsatile GNRH, it is associated with lower risk of multiple pregnancy. So ovulation rates are 75%. Pregnancy rate is 23 to 29% per cycle. Multiple pregnancy is only 3.8 with GNRH. Disadvantage of this pulsatile GNRH are higher cost and need to attach a pump for this infusion, which is not available for therapeutic use in UK right now. Gonadotrophin, it is also alternative for this pulsatile GNRH treatment. So commonly used gonadotropins, these are HMG and FSH. Okay, so HMG has both FSH and LH-like action. So that is why HMG is preferred for this type 1 ovulation, because this type 1 anovulation patient, these are also deficient in LH also. So only FSH will require more dose. So for that matter, you have to give HMG. You have to use HMG for the ovulation induction in this type 1 anovulation. Starting dose of HMG is 75 units and the increment should be done in 33%, okay, depending upon the ultrasound follicular monitoring. Cumulative conception and live birth rates with this HMG, that is in the first course and after 12 cycles. So what do you mean by first course is for at least 12 cycles, it is 82.1%, that is conception rate, and live birth rate is 65.4% in hypothalamic, hypo, and 95% and 85% in hypothalamic amenorrhea. So hypothalamic amenorrhea group, these are the more responsive for this gonadotrophin therapy also. Miscarriage rate is 22% for HH and 32% for this hypothalamic amenorrhea. OHHS is less than 1%, but multiple pregnancy is up to 30%. So as I told you, multiple pregnancy is less with this pulsatile GNRH. Growth hormone treatment. So growth hormone can be used for this hypopituitarism only whenever there is growth hormone deficiency is there. Otherwise, growth hormone supplementation should not be used. So for HH and HA, growth hormone supplementation should not be used. But for hypopituitarism, if the growth hormone is deficient, you can use growth hormone along with this gonadotrophins. So, and luteal phase supplementation, whether to give or not, there is limited evidence, but what this TOG is advocating is luteal phase should be, luteal phase support with progesterone should be empirically offered. It can be either in the form of twice weekly SCG or daily vaginal progesterone pessaries. So luteal support either biweekly SCG or daily vaginal progesterone pessaries. So this is the talk. Here the most important thing that you have to remember, most of the time these EMQs are asked regarding this pulsatile GNRH and gonadotrophin. So pulsatile GNRH you will be using for hypothalamic amenorrhea and idiopathic hypogonadism, while gonadotrophins you will be using for the primary pituitary disease. Okay, so this is the important thing that you have got from this talk. So coming to the questions, please type your answers in the chat box.
D.
See, this patient is runner, okay? Runner, and she is having secondary amenorrhea. So this is a hypothalamic amenorrhea. So for hypothalamic amenorrhea, the major thing you will be doing is the BMT. So it is C, dual energy X-ray absorptiometry. MRI or CT you will not do unless you find any neurological symptoms. Next one. Yes, again, this is a patient of hypothalamic amenorrhea because she is having this eating disorder and low BMI. Okay. So, and she is having secondary amenorrhea. She is having already receiving this nutritional supplements and psychological support. So the next thing is estrogen patch plus cyclical progesterone. And here COCs are contraindicated. So answer is C here. So thank you for attending today's session. Tomorrow we will meet with another talk. Bye till now. Bye till now.
Thank you, ma'am.
Thank you, ma'am.
Thank you, ma'am.